We'll move to the third talk this afternoon. Dan Allen from Mayo Clinic, Arizona, will talk to us about locally advanced pancreas cancer. Dan Allen comes to Mayo Clinic, Arizona after doing his oncology training at Ohio State, prior to which he was at UT Southwestern. He also worked at the NCI for their cancer therapy evaluation program. He's leading several trials in GI as well as phase 1 at Mayo Clinic. Dan Allen.
Thanks for the introduction, Pashtun. I'd like to thank the course organizers for inviting me to speak to you guys today. So my talk is treatment options for resectable, borderline, and locally advanced pancreas cancer. So just to provide you with a quick overview of which way the discussion will be going, first we'll kind of review the current treatment landscape in localized pancreas cancer, followed by an update in the treatment of both the preoperative as well as the adjuvant setting. And then lastly, we can talk about the practical implications about how we can integrate these things into our practice. And so, oftentimes we kind of think about local regional pancreas cancer as kind of defined by their anatomic location. So a lot of times we clearly define them as being purely resectable. And then the part that kind of where there's a lot of ambiguity is really defining them between borderline resectable and locally advanced pancreas cancer. So resectable pancreas cancer tends to be about 10% of patients with newly diagnosed pancreas cancer, while the borderline resectable and locally advanced pancreas cancer performs about 40%. And we kind of use that anatomic definition by really about tumor abutment involving the SMA as well as venous involvement of the SMV and PV. But when we discuss with some of our surgical colleagues, they don't kind of use this definition. So one of my colleagues in Rochester, Dr. Mark Trudy, kind of thinks about pancreas cancer in a little different limelight, more or less. And so he kind of defines local regional pancreas cancer as kind of 3 different categories. So one, we kind of think about patients with local regional pancreas cancer that truly have occult metastasis that are not going to be controlled with chemotherapy. So these are the patients that are probably not going to benefit from any surgery. The second category he thinks about is patients with occult metastasis that will likely benefit from chemotherapy. They'll ultimately have a finite benefit from surgery depending on the initial response for chemotherapy, but they'll ultimately recur. And lastly, he defines the group that are truly defined as resectable, so those that are truly non-metastatic. And these are the patients that are likely going to benefit from neoadjuvant therapy, and these are the ones that are probably going to ultimately be cured, so the ones that are actually going to benefit truly from undergoing surgical resection. And these are the ones also that have a biologically different phenotype compared to those in the first 2 categories. So we can think about local regional more like rather than a metastatic phenotype versus those that truly have occult metastasis. And so, over the past several years, we've mainly had most of the advances in the advanced setting where we've had the approval of both FOLFIRINOX as well as gemcitabine and nab-paclitaxel. And these improvements in the late stage setting have been essentially moved up to the earlier stage setting. And so a lot of the publications that we've seen